Yes, please. Thank you very much for this really very updated and intriguing presentation of what has been published in the literature. And I mean, what is your feeling, your clinical experience in managing these drugs is the first question. And the second question is, we do know that we have a cytokine storms that can be uh, managed or approached by different drugs. You mentioned tocilizumab, you mentioned steroids. Uh, if you now have to manage a patient with severe pneumonia and clinic and cytokine storms, what would you do in clinical practice?
Well, definitely I will use steroids. I'm quite convinced with all this data. And in fact, steroids, you Italians have contributed a lot to the in favor of steroids in pneumonia story. You know, Dr. Meduri has a lot of data presenting like a decade or 2 decades ago, showing that if you give steroids in patients that have pneumonia and severe respiratory failure, this might be beneficial. There has been quite a discussion. So I think we're ending up giving steroids to these patients. This is something that is something that I would do. Concerning now the cytokine inhibition story, I think that we should make trials that are a little bit more rational. There is a multi-center trial that is randomizing patients to one arm receiving monoclonal antibody against IL-6 and the others not receiving it without even measuring IL-6. So where is the signal going to be given there? So I would probably measure IL-6 and then give it. And if I remember well, you in Italy have designed a trial where you are measuring IL-6 and you afterwards trying to inhibit the cytokine if it is very elevated. So it is what you call cytokine storm. But there are other patients that are having real respiratory failure and ARDS without a cytokine storm. I don't think all patients are exactly behaving the same way. So it's not a universal cytokine storm in all patients. And we have to find those patients that would benefit from this inhibition. And this is a little bit more personalized medicine approach.
Yes, fully agree. Also, our experience with steroids is very positive, and in fact, we participate to a multi-center trial run by Marco Confalonieri and Umberto Meduri that you just mentioned about the use of methylprednisolone and steroids, and the paper is submitted for publication. But in the clinical practice, I fully agree. Steroids may help several patients. And I also fully agree that the spectrum of the disease is very wild, and we can have patients with different presentation. And sometimes we have the feeling that it's very difficult to interact to the disease progression and the clinical course with treatment and with other drugs, also antiviral drugs. In some way, we have some way a passive and very frustrating condition. Any question from the floor?
Could I ask a question?
Miguel, unmute your microphone, Miguel.
Sorry. Well, thank you very much for a very nice presentation. I would like to make a question that is more philosophical, because we need therapeutics now, but you spoke about medications that are used already for other indications. Do you have any news about the development of new drugs directly for coronavirus? And if not, do we have a connection about the immunity of this virus that allow us to see what we have to block in the immunity of this virus?
Well, this is a whole presentation, what you're asking as a question. There has been quite a few drugs that in vitro have been found to be active or designed for respectively the coronavirus. There is a Cell paper showing that there is a specific inhibitor of the attachment of the spike protein in the ACE2 receptor. But honestly, my understanding is that these are quite long away from being clinically applicable. And it is quite unexpected that we could translate in vitro results into clinical efficacy trials within 4 or 6 months. No matter how quickly we have to run or we want to run, it's really very, very difficult. And you better know that from the time that we decide to start phase 1 trials until we have a drug that can be administered to humans, it takes years. It's not that easy. Now, concerning immunity, this is a huge area. Of course, the majority of patients develop antibodies. And the question is if these are protective or are only given or are only being generated as a marker of disease, if they're specific, and how long do they last? And I think we don't have the answers to any of these questions because we have just starting seeing these publications about the antibody responses, and we don't know how long these are going to last. If you take the example of other coronaviruses, the coronaviruses causing the common colds are short-lasting. The close relatives of this coronavirus, the SARS and MERS, were a little bit longer lasting, but there was the problem and the good thing, which is not good, that people died like 10 or 34% in SARS and MERS. So if you die, you don't transmit the virus. So it's a little bit difficult to make extrapolations. In terms of immunity, I think we have the next speaker that is going to tell us how fast we're going to move there. And probably we should keep on having this discussion after the next lecture.
Okay, for me. Another philosophical question, sorry. We are now in the precision medicine era. Do you feel that maybe when we apply these drugs, when we are studying these drugs, we are studying different phenotypes, and if we make some genetic studies from the background of patients, maybe we see that in some patients, in some group of patients, some of this medication will work and another no. So I'm not aware of any studies about the genetic background of the patients. Do you feel that we could be more, how can I say, we could do a more precise medication, and we know very well how the drugs work if we know better this subgroup of patients?
What you are suggesting is very rational, logical. In fact, these studies have started appearing. There is a very recent study in the New England Journal of Medicine about genome-wide association studies about certain loci that are associated with the blood groups, showing, for instance, that If you have A blood group, it is a little bit more susceptible. O blood group is a little bit more protective. So these studies are going to appear more frequently. But in the majority of diseases up to now that I'm aware, despite having a lot of genome-wide association studies, the majority of these results are just descriptive and have not been really linked to clinically applicable therapeutic decisions. It's only in cancer where some genetic traits, let's say, give specific hints to specific therapies. Is not in the majority of other diseases. We're talking about personalized medicine in COPD or in asthma or whatever, but it's not like in cancer. In cancer, you see that if you have this mutation or if you have this percentage of expression of that protein, then you give this immunomodulatory drug and this works. Certainly at some point we will end up there. That's the future, it's obvious. But I think we're quite far in terms of the coronavirus. In fact, it's a 6 month disease.
Okay. So I would like to give the last comment to Yannis Choumis from Thessaloniki. She's an expert in infectious and also pneumology, so I would like to have his opinion.
I would like to go back to the corticosteroid issue. And this question goes back to the beginnings of the 50s, actually, because there were so many studies with very different results. And these studies are concluding to nothing, actually. Corticosteroids are not adopted as a therapy for infectious diseases and especially in microbial pneumonia, despite the fact that there were some positive studies. Now talking about the viral infections. Fodoros, you know that the corticosteroids were accused that they increase the seeding of the virus in several infectious diseases caused by viruses. So they think that we can give some corticosteroids, as these recent studies claim, means to me that we have to adopt some selection criteria if we would like to give corticosteroids. For example, Sanjay Sethi for the pneumonia said that we can give steroids only to persons that have very high levels of CRP. And these were actually moderate doses. What about the viral diseases and especially the COVID-19 now pandemic? Do you think that we have any criteria for the selection of the patients who could potentially benefit from the administration of corticosteroids?
What you're suggesting is very logical, is very rational, because the potential mechanisms of action of corticosteroids is reducing hyperinflammation. So yes, if you have high CRP, high ferritin or whatever marker of hyperinflammation, this is where most likely corticosteroids are going to work. In fact, there are some infectious diseases where corticosteroids are beneficial. If you go to meningitis, bacterial meningitis, then corticosteroids are useful. So wherever you might be having hyperinflammation in some disease states, corticosteroids might be useful. And as you suggest, we have to find for which patients. For instance, the recent recovery preliminary report said you don't have to give them unless your patient needs oxygen or mechanical ventilation. This is something.
A small introduction. Yes, Professor Danakis.
I think we have to stop here and maybe at the end of the webinar to discuss more, because I think our speaker from USA is waiting a lot of time, and I pass to the last